All right, welcome everybody, and good evening to the Cervical Spine Research Society webinar on everybody's favorite topic, complications. As one of my mentors told me when I first started, if you're not having complications, either you're not operating enough or you're lying. And so here we are discussing all of our favorite cervical complications. We have a fantastic lineup of speakers today, including leading spine surgeons as well as a colleague from ENT as well. And we all want to hear that perspective as well with regards to some of these complications. Really honored to join you here with my co-moderator, Dr. Lee Tan. And I want to remind everybody that the official journal for the CSRS is CSS, Clinical Spine Surgery. There is an expedited review process for papers focusing on the cervical spine. For anybody that has papers that they want to submit, definitely keep CSS in mind. And we'll try to get the paper expedited, especially if it's a cervical paper. And then for those with social media and social media accounts, all right, I'm going to pass it over to my co-moderator here, Dr. Tan.
All right, thanks, Elias. I just want to take a brief moment to thank Maria and Allison who put a lot of work into, putting the webinar series together. And one nice thing about this is that, everything is recorded. So it's great that, all the attendees today can watch it. But if you really like the topic, you can go back and watch it if you missed something, someone said. And also, please let your friends know that this is be archived and it'll be on available on YouTube for your reference anytime. So I think that's a really nice thing to have and have the authorities and experts to talk about a particular topic to help us getting better at our craft basically. Okay, so here, again, three presentations. So, Dr. Fontes will go first, and then Dr. Bobby Tay, and then followed by Dr. Stephen Chen. And then at last, we'll have some more Q&A. Next, we're going to move on to the next talk, which is presented by my friend and colleague, Dr. Bobby Tay, who is an orthopedic spine surgeon at UCSF. And he has decades of experience and is an expert in cervical spine surgery. He's also the chief of orthopedic spine here at UCSF. So without further ado, we'll have Dr. Tay give us his talk.
Good evening, everybody. I'm Bobby Tay. I'm one of the speakers tonight for this webinar on complications and management of complications cervical spine surgery for the Cervical Spine Research Society. I don't have any applicable disclosures for this talk. The overview for my talk is as follows. It's on the recurrent laryngeal nerve, its injury and its management. We're going to go over why injury to this nerve is important, what the relevant anatomy and the function of the recurrent laryngeal nerve is. We're going to try to answer some questions that are important to me as a surgeon. And those are, does the laterality of the surgical approach matter? What surgical levels have the highest risk for injury? Is incidence of recurrent laryngeal nerve higher with more levels and in revision surgery? What is the deal with this ET2 business? And is it important for us to deal with, or is it not as important? And then finally, how do we manage it? Mainly, how do we prevent it if we can? And how do we manage it when it does happen? So let's start. Always good to start off with a case. And the first case is my patient that came to me from the Midwest with this operation already done. She had multi-level anterior and posterior spinal fusions in her cervical spine for really neck pain and mild radicular symptoms. She subsequently did well after all this surgery, but then developed adjacent segment disease with stenosis and hand dysfunction and myeloradiculopathy. This is her MRI showing the spondylolisthesis at the base of her neck. and the spinal cord constriction at those levels with foraminal stenosis. I chose to do an anterior and posterior combined cervical fusion on her, going across the cervical thoracic junction, because anatomically it allowed me to do that, and I could get a better correction of her overall sagittal balance, as well as improvements in her foraminal height and foraminal decompression, and better overall fusion stability. She ended up having a lot of dysphonia and dysphagia post-op as expected, which eventually got better. She did have a direct laryngoscopy that showed unilateral vocal cord paresis on the left side. I did use ENT to help me with the exposure, as this was a revision approach at the cervical thoracic junction. And our ENT doctors are quite good at this, and they allowed me to get there. However, we still got into the same issues with the recurrent laryngeal nerve. The recurrent laryngeal nerve causes dysphonia and dysphagia, and also occasionally can cause people to aspirate food. The interesting thing is that dysphonia and dysphagia are very, very common after anterior cervical surgery, and recurrent laryngeal nerve, both paresis and paralysis, are less common. So although a lot of people may have dysphonia, not all of them who have dysphonia have recurrent laryngeal nerve problems. However, all of them who have dysphonia should be checked out for a recurrent laryngeal nerve problem. And these problems do last. They can last over 12 months or longer in a significant proportion of patients, and up to upwards about 13%. And that is significant. So why does this happen? Well, the recurrent laryngeal nerve is at risk in the surgical approach to the anterior cervical spine, the standard Smith-Robinson approach. And specifically, it's at risk when we enter in between the carotid sheath and the deep cervical fascia. And between that and the alar fascia is where the recurrent is at risk, especially down the base of the neck below the level of the cricoid. The anatomic differences are apparent on the right and the left. The recurrent laryngeal nerve is a branch of the vagus nerve that on the left side travels down the carotid sheath and then wraps around the arch of the aorta and then comes back. That's what it's called, recurrent. Comes back between the tracheoesophageal groove up towards the vocal cords and the vocal folds. That's on the left side. On the right side, it goes down the carotid sheath and wraps around the subclavian artery and then enters the tracheoesophageal groove. Because of the anatomical variation on the right side, it enters the tracheoesophageal groove much more cephalad than on the left. And because of that, and because it has to cross over from the carotid side to the tracheoesophageal groove to enter it, is at risk for lower approaches to the cervical spine on the right side. The presentation of a palsy or a paresis can be a hoarseness of the voice, which most people are familiar with. But patients can also get vocal fatigue. They can aspirate because the closure of the vocal folds prevent food from going down your trachea. They can also get sensations of like a lump in their throat and dysphagia. The best way to figure that out is to have them go through a swallowing assessment and a direct laryngoscopy. And you're looking for, hopefully, just a unilateral vocal cord paralysis. If patients have bilateral vocal cord paralysis, they will have significant dyspnea and stridor. and that's a very bad thing. But most of the time, if we're careful, we only have, and if we do get it, it's only unilateral. And you see something like this on the picture on the right here. It's a partially open vocal fold. It's a video showing a paresis, not a plegia, a paresis of the right vocal fold. You see, there's an asymmetric opening between the right and the left side. And the right side does not close completely and does not fully open completely. And this is the right side, obviously. So we talked about the anatomical variations from right to left, but do these anatomical variations actually make any difference whatsoever on the risk? Well, this is a very classical article that's often quoted back in 2001 by Dr. Connolly. And in their retrospective review, and recurrent laryngeal nerve injury in their study was if patients had dysphonia for over 2 weeks duration, or they had laryngoscopic confirmation of vocal cord paralysis. So if you can see, there's multiple types of surgeries involved, both cervical fusions, corpectomies, and a mixture of them, multiple levels involved, and really no significant difference between the right and the left side on a fairly large number of patients. And because of this, we didn't necessarily feel that there was any significance between approaches from the right side, which are actually easier or more comfortable for a right-handed surgeon, versus approaches from the left side, which from the orthopedic standpoint, we've all been taught that it's a safer approach for the recurrent laryngeal because of its anatomic path. It's a nicer or less variable anatomic path on the left than on the right. However, that particular study, which was in 2001, has been put into some question with further studies that both looked at right and left side approaches with little additions of endotracheal cuff deflation and to try to decrease the pressure on the laryngeal wall and on the recurrent laryngeal nerve. But as an aside finding from the study for the endotracheal tube, there's also found that these authors also found that the right-sided approach had a lot higher rate of both hoarseness and recurrent laryngeal nerve dysfunction, as noted by direct laryngoscopy, than the left-sided approach. As you can see in an earlier study, shown in the very bottom, table 5, at 3-month follow-up, from a right-sided approach, the incidence of recurrent laryngeal nerve dysfunction was 13.3%. And whereas from the left side, in the same surgical treatment of the patient, same numbers, it was only 6.5% from a left-sided approach. If you drop the endotracheal tube pressure and repressurize it with a lower pressure, you actually decrease the risk or decrease the incidence to 1.3%. What's also notable about this study is that a lot of patients had recurrent laryngeal nerve palsy without hoarseness. Almost twice as many patients had recurrent laryngeal nerve palsy without the typical hoarseness that would make us suspect that they have a problem. So a lot of patients that we take care of that have a fairly normal voice and normal phonation or have minimal change in their phonation may still have a problem with the recurrent laryngeal nerve on direct laryngoscopy. So when you see a patient that had no issues with their voice after a cervical surgery and you're still doing revision surgery on them, if you decide to do revision surgery on them for another issue down the line, you still should get a direct laryngoscopy and check their vocal cords. So another set of studies that suggest that the left side is a little bit more safe than the right are these anatomic studies that suggest that there are fewer branches of the recurrent laryngeal nerve on the left side than on the right. And these are cadaveric studies assessing the number of bifurcations and trifurcations of the recurrent laryngeal nerve on the left and the right as seen above. And over on the right side, you can see there's many more bifurcations and trifurcations and multiple branches on the right side versus the left. And because those little branches are really hard to find and see intraoperatively, the left side might be a little bit safer to approach from an anatomic perspective. You can see same thing. This is in regards to its the recurrence location versus the inferior thyroid artery. The inferior thyroid artery is not something that we as spine surgeons tend to see, but when you do thyroid surgery, you use it as a landmark for where the recurrent is. So which levels are at the highest risk? Well, since the recurrent is traveling in the tracheoesophageal groove, anything above the level of the cricoid, anything below the level of the cricoid, which is around C6, C7, is at risk. So the levels that are most risk are at C7, T1. And there are several studies that suggest that the lower the levels around C7 and T1, the higher risk it is for the recurrent for injury. This was a classic article by Ron Applebaum that was actually for a different purpose. It was to assess the role of EET2 cuff pressure on recurrent laryngeal nerve injury. And this, as an aside, looked at the levels that had the highest risk for recurrent laryngeal nerve injury and found that a lot of these occurred around C7 and a lot occurred around T1. And in this area, anatomically, on the right side, the recurrent laryngeal nerve, because it crosses over a little bit higher, is at greater risk for traction injury from surgical exposure and stretch. So this was a nice anatomic study showing that the nerve is in the deep cervical fascia, middle layer of the deep cervical fascia, and it is at risk for stretch injury when you're exposing that area with retractors. It does not occur on the left side because it enters the tracheoesophageal groove at a much more caudal location. So, to our next question. Is the incidence of recurrent laryngeal nerve higher when you do more levels? And that's a yes. So the more levels that are done, especially more levels going down near the cervical thoracic junction, the more chance that you have of injuring this nerve. This study shows it's very hard to see. At the very bottom is the key statistics. 3 levels and 4 levels have actually, if you go above 4 levels, 4 or more levels, you have a much higher risk, almost a 6-fold greater risk than if you go 3 levels and below. Also, in reoperations, there is a suggestion that that nerve is at greater risk, a higher risk for dysphagia and dysphonia. Upwards of 14.1% incidence of dysphonia, dysphagia, and clinically proven vocal cord paralysis with redo anterior cervical surgery. So finally, what about this ET2 phenomenon? Well, this started off with a classic article, almost a groundbreaking article by Dr. Ron Applebaum back in 2000, where he did both a clinical study as well as a cadaveric study showing what the ET tube does when you put a cervical retractor in the area of the cervical spine to give you the exposure. You see that it's not the cuff of the tube, it's not the cuff, but it's actually the tube itself that the retractor is pushing up against. And between the tube and the retractor is a recurrent laryngeal nerve. And if you deflated the tube, it allowed the tube to center a little bit better and decrease the pressure, the pinch pressure on the nerve itself as it goes up the tracheoesophageal groove. And he found in his pretty landmark study at that time that his incidence of vocal cord paralysis diminished significantly when he deflated the ET tube and reinflated it to around 20 millimeters of mercury after the retractors were placed. And that led to a lot of people worried about, what should I do about this ET tube and what I need to do about this cuff. And people needed some guidance. And interesting enough, there was a follow-up study by Alex Vaccaro, Todd Albert, and all the group at Rothman. And they didn't find any difference between deflation, reinflation, and pressure adjustments on the ET tube and their rate of recurrent laryngeal nerve paralysis or palsy. And what they did find was that there was a suggestion that a left-sided approach had a lower incidence of recurrent laryngeal nerve injuries than the right-sided approach. Everything else between the patients were very much the same, including the amount of retractor splay, as well as the measured pressures. The measured pressures were actually very different between the patients who didn't get a recalibration of their ET cuff and versus those who did. But the incidence of recurrent laryngeal nerve injury were not that different. So statistically, the intervention group had a 8.2% rate and the control group had 12% rate, which was not statistically significant. However, what's notable is that the hoarseness was greater in the control group. So the ET cuff pressure and reposition of the ET tube in the trachea after retractor placement may have an effect on patients' hoarseness as well as sore throat. But in regards to real laryngoscopy proven recurrent laryngeal nerve paralysis, it does not seem to make a huge difference. How about the way we intubate patients? So there's an interesting study looking at both oral intubation versus nasal intubation on the dysphonia after anterior cervical spine surgery. And the authors found that when you nasotracheally intubated the patient, those patients had less dysphonia. And they thought that was more due to the fact that when you put the tube through the nose, the tube is centered better than when you put it in the mouth. And it's interesting when I looked at my patients these days and our anesthesiologists, when they put their bite blocks in for their neuromonitoring, they actually center the ET tube in the mouth because they put bite blocks on both sides of the molars. So I think it's interesting because a long time ago, we just used to tape it on one side and maybe put a bite block in the middle. But now that we put bite blocks on both sides, actually the tube itself is centered better. I think our dysphonia rates and dysphagia rates have diminished because of that. So management, finally. Well, the first part of management is truly prevention, right? And how do we prevent this from occurring? Well, we have to know when we're at greater risk of injuring it. And these are high-risk situations like multi-level revisions, revisions to the lower cervical spine and cervicothoracic junction, even um, primary anterior approaches and anterior surgery at the cervicothoracic junction, especially around T1. And in those particular cases, it's probably worthwhile to get our ENT colleagues to come and help us for multiple reasons. Our ENT colleagues will allow, often they have a program preoperatively so that you can send the patients for a preoperative speech and swallow assessment. And sometimes there's a subset of patients that have some paralysis or dysfunction of their vocal cord prior to the surgery itself. And those patients can be identified so that when there's something happens after the surgery, then you're not really blamed for causing it. You could certainly cause a new problem. However, if they have the same old problem and they have issues associated with dysphonia, it could be from other reasons other than for the vocal cord. In addition to this, if they have issues post-op, our ENT colleagues are well um, uh, well trained in treatments for the vocal cord, and also they give you advice and the patient advice on how to manage it conservatively with voice therapy and all sorts of stuff. We try to avoid right-sided approach to C7T1 because anatomically, that's where the recurrent laryngeal nerve is at greatest risk for a stretch injury. And in patients who are high profile, things like singers and people that require their voice for a living, a normal voice or their particular voice for a living, then you may consider pulling out all the stops, doing a nasotracheal intubation, ENT approach, cuff deflation, and those are very specific cases. Once you get this problem, though, most of the patients will recover from a stretch injury over a 6-month period, and it takes at least that long. And a lot of patients will still have problems with dysphonia, albeit things that most of them can live with even at 12 months post-op. Temporary treatments include vocal cord injections, voice therapy. Permanent treatments include thyroplasty, vocal cord surgery, reinnervation surgery, and Teflon injections. So from that, I want to thank you for your attention, and I learned a lot from preparing this, and hope you also learned something useful. Thank you again.
Thanks, Bobby. That was a fantastic review and fantastic talk.
I had a question maybe for Dr. Tay. When you look at sort of dysphagia and just pain, difficulty swallowing, you never really think of it as a big complication. It's almost like sort of like, yeah, this is going to happen. It happens to almost everybody. But some of the worst cases I've had were actually with older patients. I feel like those above the age of sort of 70, 75, even 80. So I was wondering what your experience was with regards to older patients, and if you're doing like a multi-level, let's say like a 3-level ACDF, would you tend to just go posteriorly for that sort of demographic of patients, given sort of dysphagia risk, or any other sort of tips and tricks that you have for that age group?
Yeah, I think that's a great question. I think if you look at the older age group, especially females, their bone quality is pretty bad. So when you do a multi-level ACDF on them, sometimes they have a high chance of basically settling down and subsiding their grafts unless you use big cages, I guess, to fill up the ring apophysis, fill up the disc space up to the ring apophysis. And maybe Lee can give a assessment of how those people do how those types of cages do an osteoporotic bone. But John Rhee while back suggested that if you use cages, then you have less subsidence. But a lot of those patients have multi-level cervical disease. And if you are thinking of doing a 3-level fusion on an osteopenic patient, they're probably not going to heal at least one of those levels, and you're going to go posteriorly anyway, eventually. So unless they have like severe weakness or something that you want it, and a big uncle spur that you really want to go off and attack and try to get them better, which very few of them do actually, going posteriorly, I think, is a better way to go.
Sure.
And posteriorly, there's like options like laminoplasty as well as laminectomy fusion.
Yeah, yeah,
Yeah.
yeah.
Bobby, the funny thing is, I think, there's dysphagia from posterior surgery as well. It's not a non-zero risk, from the intubation and whatnot. But I do have one question for you, Bobby, because you give such a great talk on the recurrent laryngeal injury. From your talk, we know the direct injury is much less. Most of it is traction injury and neuropraxia from the nerve. Is there any sort of tips and tricks you can give the audience? Do you use skinny retractors or wide retractors? Do you prefer to have it sit under the longest muscles, or what are your tricks to minimize those traction injuries of the nerve?
When I'm working, when I'm working underneath, below the cricoid, I try to get up and go. I don't like to spend very much time there. And I tell our fellows and residents, like, this level, we're going to have to do it very quickly. And the other levels above the cricoid, 4, 5, 5, 6, most of the issues are probably with endotracheal nerve cuff, uh, kind of irritation of the esophageal, of the tracheal wall, or laryngeal wall, versus a true recurrent problem. And then as you go up higher, you have to worry about the superior laryngeal nerve, right? But from the recurrent standpoint, I don't waste too much time trying to go fast at 6, 7 and below. And then, as you know, if once you're going down to the very bottom of the spine, it's like the longus is fairly small, and your retractors don't really stay underneath the longus very easily because of the lordosis. And so it's not an easy place to put in retractors without having some undue tension on the tracheoesophageal groove on one side and the carotid on the other. So again, we kind of giddy up at 6, 7 and below. Long time ago, when we used to use handheld retractors, there were surgeons that said that when they used handheld retractors, they didn't have very many problems with recurrent laryngeal nerve injuries, because their hands would the assistant's hands would really tire out, and they'd like let go. So the pressure would be on and off, not like these self-retainers that we currently use.
And I think the key things here are really sort of not putting your head in the sand with complications, right? So recognizing complication, sort of prompt recognition, prompt treatment, and really like recruit the help of colleagues, whether they're other spine surgeons, that are willing to come in, when you have a bad injury or anything like that, or even something you're not really sure about, like just it's always helpful to have another set of hands in there. And then of course other colleagues, and take a multidisciplinary approach, and then sort of getting the patient what they need. So thank you very much. Appreciate everybody joining us.